Talk about today's lateral chest X-ray. I did a video Wednesday on PA and AP chest. So we're going to do lateral chest X-ray today. So we're going to not just talk about positioning, but we're going to look at some images. We're also going to look at image analysis and correction. So if you're a first semester student, then this is the image analysis and corrections is going to be great information for you, but it's probably going to be advanced for your position in the program that you're in and probably beyond what you're going to be tested for in the first semester. But it's great information to know for how to correct your images. Your lateral chest X-ray is going to be the first hard thing that you're going to learn and you're going to perform in clinicals, and you're going to have a hard time determining how to reposition. So the general rule of thumb, whenever you're repositioning and you're repeating an exam, is that you have to make an analysis of what you did wrong before you go back in and reshoot the exam. If you you think you position properly, the image comes out improper, and you go back into the room, you reposition exactly the same way that you did before without any kind of correction, then you're going to be surprised that you get exactly the same image. Um, I've seen this happen before. I've seen new students that thought that they knew what they did wrong, and they went back in and before they made the exposure, they were stopped because they were making the same mistake a second time. For example, on a lateral chest X-ray, one of the things that you have to do to get a good lateral chest X-ray is get the arms out of the way. So this image is going to, or this video is going to have some demonstration in it. So you're just going to have to bear with me on that. I'm going to have to move around a little bit, but the point I'm trying to make at this point is that in order to see a good lateral chest X-ray, one thing that you're going to have to do is get the arms up and out of the way so that the patient, the patient's arms, their humeri and all the soft tissue isn't overlapping the lung field. So I've seen students forget to do that, forget to elevate the arms and get them out of the way. And so they go back into reposition, and just before they make the exposure, the technologist stops them and says, "How about the arms?" And sure enough, they get the arms up and out of the way. So you have to change something. The purpose for critique is to limit the number of repeats that you make to just a single repeat. So with that in mind, let's get into it. Just a review of anatomy on a lateral chest X-ray. What we're trying to accomplish on a lateral chest X-ray is to get a three-dimensional. One of the big reasons that we do a lateral chest X-ray is get a three-dimensional perspective. People are three-dimensional, so we have a width, a height, and a depth. But what we see on an X-ray is two dimensions. You see height, you see this dimension and that dimension. So you see height and width, but you don't really see depth very well. So we're going to take a look at anatomy here in a minute, and we're going to see why it is that it's important that we get three dimensions, a three-dimensional perspective. So the things on a lateral chest X-ray that we need to be cognizant of is that we do have an apex of the lungs, but I also want you to notice that the costophrenic angle, the posterior costophrenic angle, is much lower than what you see on the PA. So on the PA, what you see is the dome of the diaphragm, but you don't see necessarily this back here. You might see this if you were to be shooting an upright abdomen. That would be the dark area on the upper portion of the abdomen. But for the most part, whenever you're looking at a PA chest X-ray, what you're looking at on the costophrenic angles is not this entire back area. So you have the top to the bottom, you have the front to the back. What you want to see are the superimposed posterior ribs. So these are not completely superimposed, but this is nothing to get in a big twist about. What we want to see is adequate penetration of the thoracic vertebra. The ribs really should not stand out very well. You've got the shadow of the heart here. The sternum is very difficult to see. The trachea you can see, but it's kind of tough. The esophagus you really can't see because it's a collapsible tube that lies behind the trachea. The scapula you can't see all that well. So the main things that you want to be able to visualize are the, certainly the vertebra, but you want to see the posterior ribs, you want to see the costophrenic angle, and you want to see the apex of the lungs. So your positioning for a lateral chest x-ray then is this, that you need to include all that stuff. So keeping in mind that the costophrenic angle drops down lower on the posterior side, and that the shoulder kind of covers up the very top portion of the apex of the lungs. We might do a little bit of a tweaking to our chest X-ray and our positioning of our central ray and also of our image receptor. Now, I'm going to do another video that goes through decubitus, chest X-ray. I'll touch on obliques, but we really just don't do a whole lot of obliques. Decubitus chest X-ray, apical lordotic X-rays, and with the exception of the apical lordotic, what you need to file away in your mind is that all chest X-rays, the centering point for your central ray is T7. All right, so keep that in mind, but at the same time, be a little bit flexible in your thinking here in just a minute, and I'll get to that in just a second. So what we're looking for is three-dimensional perspective. We want to be able to visualize the lobes and have a working knowledge of what the lobes of the lung look like. So in the lung, what we have is 5 separate lobes. In the left lung, we have 2. In the right lung, we have 3. I'm going to close this out just for a second, and I'm going to scroll up to a different portion of this PowerPoint and show you what I'm talking about. So what we see in the lungs is that we've got 1, 2, 3 lobes. But if you look at the lobes, what you see is that it's not as cut and dry as saying we have a superior lobe, a middle lobe, and a lower lobe. So the lower lobe extends from the bottom of the lung close to the top of the lung. Middle lobe is, truly in the middle, but it also has some contours that makes it very difficult to identify exactly what portion of the lobe the middle lobe is. So if you look, it goes from about the middle of the lung all the way down to the base. And then the superior lobe likewise goes from the top almost to the bottom. So even though, what we're talking about in the position of those lobes is either what's at the top or what's at the bottom. So they cover a lot of territory. So the point I'm trying to make is this: is that in a PA chest X-ray, if we have a lesion that shows up in one place, it makes it very difficult to identify exactly where that lesion is. So we've got this thing here, this image here, and they conveniently colored this particular, lesion. So what we see, this is the raw X-ray. What we see is probably, I'd mentioned in the previous video, the cancers look very subtle. So this very well may be a cancer, and we can't identify exactly where this lesion is. It looks like it's an upper lobe, and it probably is an upper lobe just off the PA. So if we look at the PA and we look at the lateral, we get a better understanding of where that lesion might be. So if that lesion was down here in the middle of the lung, it would make it very difficult to identify just off of the PA whether it's in the upper lobe, middle lobe, or lower lobe, because it could be in any one of the 3. So if you were to take your lobes and just kind of slice them across this way, you got upper lobe, middle lobe, and lower lobe. And that was down here somewhere in this area, but posteriorly, then you would have telltale indication that possibly what you were looking at was lower lobe, or you could identify something. So this circle indicates the patient has a broken shoulder, maybe a pathological fracture. Pathological fractures are fractures that occur because of the weakening of the bone for whatever reason. Maybe it's osteoporosis, or it could be metastatic cancer in this case. So the reason we do the lateral chest X-ray is to get that three-dimensional perspective. and we carry that through into things like upper extremity, lower extremity. So in your camera, you're only seeing two dimensions. So if I were to put my fingers kind of close together like this, it looks like according to the camera, it probably looks like they're pretty close to touching. And they are, but it probably also looks like they are pretty much right on top of each other, as opposed to if I turn them just a little bit, you can see that there's a little bit of separation front to back as well. So again, we do x-rays in different dimensions so that we can get a better three-dimensional perspective of what it is that we're looking for in a chest x-ray is no different from that. Now, all that being said, I've been to seminars where radiologists say that their hospitals and their doctors have stopped taking lateral chest x-rays. The reason for that is because, again, if this were to be dead square in the middle of this lobe, and dead square in the middle of the lung in this image and dead square in the middle of this one, then chances are they're going to have a tough time identifying exactly where that is anyway, and the patient's going to go to CT. Even without that, this patient's going to CT. I've heard it straight from a radiologist's mouth that they've stopped shooting lateral. So that might be something that you may have to adjust to in your career. You may not, shoot PA and lateral. PA and lateral being your most common routine for chest X-ray. May just go straight to AP or PA projection. So we do the lateral for three-dimensional perspective so that we can identify the lobes and where the pathologies might be, but also to remove superimposition of things. So that's not uncommon for laterals or oblique projections as well. So how we're going to position for our lateral chest x-ray is patient's going to be upright if at all possible. Again, just like on the PA for the same reasons as the PA. And we're going to shoot a lateral with the left side up against the image receptor. And the reason for that is because your heart, even though it might be at midline, your left ventricle is the largest portion of the heart. So we want to put it closest to the image receptor so that we don't have that magnification of the heart. Positioning wise, again, your textbook positioning is just like on the PA, and that is with the top of the image receptor 1.5 to 2 inches above the shoulder with your central rated T7. So again, on your breathing instructions on the patient, if you shoot your lateral first, then certainly do 2 deep inspirations. But if you're shooting your lateral after you shoot your PA, then a single deep inspiration is sufficient. You've already got the lungs expanded from the two inspirations on your PA. So 1 deep inspiration on your lateral will suffice. Now, here's the thing. We put the left side up against the image receptor so that we put the left heart up against the image receptor, but there's a kind of a natural phenomenon that happens. I talked about the divergence of the central ray in the last video, and what that means is the spread of the central ray. So where you get into the periphery of the X-ray beam, you've got an angulation, and what that means on the X-ray is that whatever's furthest away from the image receptor is going to move the most. So your left lung being close up against the image receptor is going to be less affected by the divergence of the central ray than your right lung. And that's really kind of what we want, because the right lung naturally is not as long as the left lung in normal anatomy. And that is because of the placement of the liver. The liver, primarily being on the patient's right-hand side, has that right hemidiaphragm elevated just a little bit. So that whenever we position the patient in the left lateral, we get 2 things. One is less magnification of the heart. We're going to shoot at 72 inches to further reduce that. Also at 72 inches, the divergence of the central ray is not as great. But also what it's going to do is it's going to take that right hemidiaphragm and it's going to project it down almost directly onto the left hemidiaphragm. So the 2 are almost going to be superimposed on your image. They should be almost at the same level. So even though the right diaphragm is higher than the left diaphragm because of the divergence of the central ray and its magnification or its distance from the image receptor, they should be almost the same. So your central ray T7, I'll put this in red for a reason, and that is because on the next one, it seems to contradict what it just said. So it says lower the central ray 2.5 centimeters from the PA. And so I would refer you back to what I was talking about before, and that is because you just don't see the apex of the lung quite as well as what you do on the PA because of the humerus. Even if you position properly, the humerus and soft tissue of the humerus, you just don't see the apex of the lung. But also, the posterior costophrenic angle is so much lower on the lateral, it's probably a good idea to go ahead and drop your image receptor and your central ray about 2.5 centimeters. That's not a lot. That's only about a half an inch. So it's not, it's not a tremendous amount. And it seems to be a contradiction from previous slides. So 2.5 inches or 2.5 centimeters, that change is going to lower us a little bit. Is it going to lower us past the point of T7? The answer is probably not. It's only a half an inch. 2.5 centimeters is roughly half an inch. So we just talked about that and why it is the divergence of the central ray is going to project that right diaphragm lower. On our lateral chest X-ray, we want the patient in true lateral position. How you're going to accomplish that, you've got some challenges. So you shoot your PA, have the patient rotate the shoulders forward, hands on the hips, rotate the shoulders forward, inch and a half, top of the image receptor, inch and a half above the outer portion of the shoulder, central ray to T7, deep breath in, blow it all out, second deep breath in, hold it, you make your exposure. You tell the patient to breathe, you walk back out into the X-ray suite, and what you're going to do is you're going to tell the patient to turn and put their left side, turn 90 degrees, however you want to describe it, turn and face that wall, right? So you're going to point to the patient where you want them to be facing. I want you to turn your body and face towards that wall. I recommend that you tell the patient to put their feet together and point their feet at that wall. The reason for that is because once you get their arms up, then what's going to happen is that sometimes the position of their arm on that wall bucky may turn them. So if their feet are pointing in one direction, you have a better chance of having the rest of the patient's body pointing in the same direction. So if there's a lot of different ways to get the arms out of the way, you can have the patient put the arms on top of their head. If you happen to be working with a machine that has the grips, then you want to have the patient reach up and grab the grips, maybe keeping their hands together. And the reason I say that is because if their hands are further apart, then that may introduce some sort of rotation. Also, tell the patient not to pull on the grips. I've had patients reach up and grab that with both hands like they're on American Ninja Warrior, like they're getting ready to swing on them. It's just for hanging on to. It's just for putting their hands on to get their arms out of the way. So tell them not to pull on it. So true lateral position, what we want is the mid-sagittal plane parallel with the image receptor. We want the mid-coronal plane perpendicular to the image receptor. You want their shoulder in contact with the image receptor or the vertical grid device. That comes with a caveat. If the patient has broad hips and their hips push them out and away from the image receptor, the last thing that you want is to have the patient lean into the image receptor, because then that's going to take that mid-coronal plane that should be parallel to the image receptor and it's going to tilt it. All right, so we don't want that to happen. So have the patient turn and then watch the patient. And, if you have a patient with broad shoulders and narrow hips, it's okay to tell them, I want you to put your shoulder up against it. What you don't want to do is tell the patient, I want you to put your side up against it. Because in that case, if you've got a patient with broad shoulders and narrow hips, they're going to have a tendency to lean into it, which again is going to take the image receptor and you've got your mid-coronal plane and they're going to lean out away from it. We're going to take a look at some images here in a minute and see what that's going to look like when that happens. So something should be in contact with the grid, but the patient, the weight should be even on the feet, and the patient should be standing upright. Get the arms up over the head. You can flex the elbows a little bit, but what you don't want to do is have the arms straight out in front of the patient. Soft tissue of the arms and the humerus will overlap the apex. They got to get them up. If it's on top of the head, that's fine. If it's holding onto the bars, that's fine. You may have to drive the bars up high enough to get that superimposition off of the apex of the lungs. If the patient's not, able to do any of that, then I had a patient one time that had she had an above elbow amputation, and her arm was if you okay, so if you don't use muscles and you don't use bones, and you don't use your joints, then the joints stiffen up, the muscles atrophy, and the bones deteriorate. So this patient couldn't move her arm out of the way, and so we had to shoot a lateral chest X-ray with exactly what it was. So if the patient can't perform it, the patient can't perform it, but try to get the patient's arms up and out of the way. You can also use an IV pole. Again, keep in mind the IV poles move, and if the patient starts leaning on the IV pole, that could be a bad day for the patient. They may, the IV pole may get out from under them. So on your image, you want to look for evidence of proper collimation. Some of your patients, you're not going to be able to collimate because their lungs are going to be huge. You don't want the arm or the soft tissue to be overlapping the superior portion of the lung. You want to make sure that you include that posterior costophrenic angle. You want your hilum around the middle of the x-ray, and the hilum is not unique to the lungs. A hilum is kind of an area of confluence. It's an area where stuff comes together. So in the lungs, what you have in the hilum is where your bronchial tree breaks. It goes into the left and right mainstem bronchus. And you've also got the pulmonary arteries and veins coming into and out of the lungs. So you got a lot of stuff going on in the hilum, but that's what you basically want in the middle of your image. And then you want the superimposition of the posterior ribs, and we'll take a look at that here in a minute. You want your sternum, sternum's a little bit more difficult to see. Um, let's see, anything new and all that stuff, and it doesn't really look like it. You want a sharp outline of the heart and diaphragms and that would indicate the patient was not breathing. You had a good instructions, good participation from the patient, but you also had short exposure time, so you didn't have any kind of motion there. So you want penetration of the lung field, the heart, the ribs, and all that. So again, it looks like this. Most of the time we're going to do left lateral. Don't forget to put your side marker on the image, but also make sure that it's not in the anatomy. So they could have collimated down on this a little bit, and then move that marker in somewhere that it would still be in the light field, but not in the anatomy itself. All right, so what we want is no rotation. So this one you're not really going to be able to visualize, but over here what you can see is you see this line, this light line right there. This will be an area of low density. Low density means it's bright. It's wider than the rest of the image or whatever. So we have low density, and then we have an increase in density, and you can see these little stripes. Those stripes are ribs. So what we've got then is we've got rotation, because these are also ribs. You just can't see them quite as well as what you can these over here. So you've got rotation. The Martinson book says you need less than a half-inch rotation, and I'm going to tell you that most of your hospitals are going to be more forgiving than that. Half an inch is probably a good rule of thumb, but most of your hospitals, most of your doctors are going to be a little bit more forgiving than that. Lateral chest X-ray this is a very good positioning, lateral chest X-ray, and sometimes it's difficult to get a lateral chest without any kind of rotation. So a couple of things on this particular image. One is make sure that you get your arms up. So you can't see the apex of the lungs, really the anterior portion of the lung at all, because the arms aren't up and out of the way. They just had the patient probably stick them out in front of them, elbows bent, and then we've got a lot of superimposition over the anterior portion of the lungs. So have the patient, make sure you have the patient put the arms either straight up over their head. If they can't hold them up over their head, have them fold them across their head. Have them hold on to, something to try to get them out of the way. This was performed with the patient in the bed. You can see this thing behind the patient, and then you've got the bed behind that thing. So this is good positioning for that. What you need to keep in mind is most of your patients who can't get out of bed, especially, and we're doing a lateral chest X-ray on her, they're sick. That's why you can't get them out of bed. And what happens in a lot of cases is, try to put yourself into this situation where your legs are out straight and somebody sits you up at a 90-degree angle. Um, you might be young and thin enough that this doesn't make a whole lot of sense to you, but most people in Northeast Texas have a gut. So the gut hits the thighs and you can't compress fluid, and it's all fluid. So what happens is that comes up and it smashes the lower anterior portion of the lungs. We'll take a look at what that does to the image here in just a bit. So good lateral chest X-ray, a little bit of rotation, nothing to get in a twist over. We already looked at those. Lateral evaluation, we want to see from the apex costophrenic angles. We don't want to see that overlap. We want to see from the front to the back without any kind of rotation. We want to see the hemidiaphragms superimposed. Hemidiaphragms, diaphragms, I'm going to use those interchangeably. Technically, hemidiaphragm is the better word if you're only talking about one. So hemidiaphragms superimposed would be left, right, superimposed. And then proper image receptor placement, collimation, and making sure all of the patient's demographic information and the side markers are on the image. So common mispositioning errors, I've already talked about some of this, and that would be mid-coronal plane positioning. So your mid-coronal plane should be perpendicular to the image receptor. Mid-coronal plane goes through the patient from left to right, or right to left. It goes across the patient laterally, and it should be perpendicular to the image receptor. So if we have non-perpendicularity, then what we have is rotation. We want to look for that soft tissue superimposition. Also, though, we want to look for mid-sagittal plane and whether or not it's parallel to the image receptor. So your mid-sagittal plane should be parallel to the image receptor. But if you've got leaning, because you've got a patient with broad shoulders and narrow hips, and you told the patient, I want you to put your side up against there, and they're trying to accomplish what you told them to do, and they put their side up against there, and they're leaning out and away from the image receptor. Or if you've got a patient with broad hips and narrow shoulders, you tell them, I want you to put your side up against there, and they lean into it. Then you have a situation where the mid-sagittal plane is not parallel to the image receptor. Anterior lung compression was what we were just talking about, and I'm going to show you an image of that here in a minute. Now, you've got a number of different things that you can look at to determine what your rotation was, and it becomes complicated. So the sternum's difficult to see on a lateral chest X-ray just because all the soft tissue, even on men, you've got a lot of soft tissue that covers the sternum. You've got the pectoral muscles. Unless you've got a very thin patient, it's very difficult to see the sternum. But imagine this. Right? So the heart mainly is at midline, but the left ventricle is the biggest portion of the heart. So it sits left of midline. So if I were to turn my body like this, and I've got my left ventricle here and my right lung over here, if I were to rotate, then my sternum is going to go that way while my left ventricle goes that way. So if you can visualize the sternum anterior to the heart, so you've got the sternum and the soft tissue of the right-hand side of the patient out and away from the heart, and the heart's kind of tucked in behind the sternum. then what that indicates is that the patient was rotated towards the image receptor. If, on the other hand, you have a situation kind of like what you're seeing here, where the shadow of the heart is out past the sternum, then that indicates that the patient is rotated away from the image receptor. And again, this assumes that we're shooting the left lateral. So that's one thing that we can visualize, is the shadow of the heart and its relationship to the sternum. So one thing that you're going to want to do before you repeat an image for rotation is to make sure that you rule out scoliosis. So scoliosis is a lateral deviation of the spine. So you're going to look at the PA and you're going to look at it well and see if the spine kind of makes an S turn. With scoliosis, what you have, and we'll talk about this in spine when we get to spines, is you have primary and secondary curves. So the spine curves and the body tries to correct the curve and put the center of gravity in the spine. So you have primary, secondary curve. But with those lateral curvatures, what you also get is a little bit of rotation, and you just can't overcome it at all. So before you repeat a lateral, make sure you look at the PA and see if there's any scoliosis. Scoliosis can also occur because of compression fractures. So if your patient has osteoporosis and they've got multiple compression fractures in their spine, then they can get a little bit of curvature in scoliosis as well. The easiest way to identify rotation and tilt, actually, is to look for the gastric bubble. Most patients are going to have air in the fundus of the stomach. The fundus of the stomach is the very top of the stomach. So most patients are going to have that air in the top of the stomach. That's what we refer to as the gastric. So again, what you should have are the domes of the diaphragm superimposed. So if we have a situation where the dome of the diaphragm, let's say this would be our gastric bubble, the domes of the diaphragm are superimposed, the gastric bubble, shouldn't be an issue. But if we have a situation where the gastric bubble is posterior, what that means is the patient was rotated towards the image receptor. If the gastric bubble is anterior to the diaphragm with the gastric bubble under it is anterior to the other hemidiaphragm, what that would indicate is the patient's rotated away from the image receptor. So in that case, the left lung is anterior to the right lung. In this case, the left lung is posterior to the right lung. Likewise, if we have vertical separation, then what we're going to see is this. Again, gastric bubble. So if the gastric bubble is low, all right, so you have vertical separation of the two diaphragms. If the gastric bubble is low, then that indicates the patient is leaning towards the image receptor. If the gastric bubble is high, that means the patient was leaning away from the image receptor. So again, this is your patient with broad shoulders and narrow hips, and they're leaning away from the image receptor. This is the patient with broad hips and narrow shoulders, and they're leaning towards the image receptor. So just like there are conditions that mimic rotation, there are also conditions that may mimic tilt and leaning as well. And we'll talk about that here in just a second. So this is scoliosis. This is lateral scoliosis. You can just see some, the chest, the shape of the chest just does not look really right. So we've got a lot of stuff, what would appear to be positioning errors on this image. But since this patient has scoliosis, there's not one thing that you can do to correct for this. So make sure that before you shoot your lateral, you take a good look at the PA. And if the patient has scoliosis, just understand you're not going to get an unrotated lateral. Document that and make sure that the radiologist knows it. All right, so this would be rotation where we could use the gastric bubble. So we've got a hemidiaphragm here, we've got a hemidiaphragm there, we've got the gastric bubble is always going to be, unless patients got a condition where all the organs are switched, which exists. The gastric bubble is always going to be under the left hemidiaphragm. So what we've got then is rotation with the left side posterior to the right side. So the patient's rotated towards the image receptor. So then again, we've already talked about this. It looks like that. And we've got vertical separation of the diaphragms, and we've got the gastric bubble above the right diaphragm, which again would indicate if it's above the right diaphragm, the patient's leaning away from the image receptor. And that would make sense on this patient. It does not look like this patient's hypersthenic or would be very broad. There are conditions, though, again, that could mimic this. So if you've got a patient, again, look at the PA. In this case, with this patient, what we have is the left hemidiaphragm is elevated. Why is it elevated? I don't know. It could be maybe the patient's got a phrenic nerve issue, or potentially, excuse me, I think I just leaked, but it could be, instead of a phrenic nerve issue, it could be that the patient has some sort of obstruction or partial obstruction in the mainstem bronchus, maybe a cancer or something like that causing it. So once in a while, you'll find a patient that on your lateral chest X-ray, they are so hypersthenic that if you have an oblong image receptor, you have to turn that image receptor crosswise. One of my students, I think last year, took this image, and the patient was so big that they wound up having to take multiple images to get them on the image receptor. We've got some rotation there as well, but this would just be a massive barrel chest on this patient. So nothing really new on this. Again, we've got tilt, or we've got the left diaphragm is elevated. So this is what we get whenever we have a seated lateral chest X-ray. So sometimes patients can't stand up, and you need to do them seated, and that's fine. Sometimes you got to do what you got to do. In the Martinson book, if you ever get the Martinson book and you read through it, what it will call this is foreshortening of the anterior lung field. And I disagree with the wording. The sentiment I completely agree with. But what happened here is that they set this patient up so much that the contents of the stomach and the abdominal cavity, not just stomach, compressed the anterior lung field, so it couldn't inflate very well. So again, you know, if ladies, if you've ever had kids, imagine then that, if you're too small to really appreciate this, if you've ever had kids and you try to set up at a 90-degree angle, that baby pushing on your inferior lung field would kind of give you that same sensation. So it compresses the anterior lung field, and it prevents good inflation. So I'm going to go back to this image and show you what they did right. So instead of sitting this guy up at a 90-degree angle, they just leaned him back a little bit. So if you're doing a lateral chest X-ray with a patient on a stretcher, don't feel like you've got to get the patient up to a 90-degree angle. Just make sure that they can fit on the image receptor. You can lean them back a little bit, and you can not have this issue. There we go. So determining rotation, we're going to look at the posterior ribs, we're going to look at the hemidiaphragm, we're going to look at the shadow of the heart, and the gastric bubble is just the easiest thing to look at. So there's really not a whole lot left in this particular presentation to talk about. Sometimes we do a right lateral. Most of the time we do a left lateral, put the left ventricle closest to the image receptor, but there are times that we would do a right lateral. One of those times would be if we just can't get a left lateral for whatever reason. But the other would be if there's a specific lesion, some sort of pathology in that right lung that they want to see, then we might do a right lateral to put that portion of the anatomy closer to the image receptor to increase sharpness of recorded detail. So we already looked at that. where you looked at all that. If the patient's in a wheelchair, you set them up as beautiful as possible without making the patient uncomfortable. Just make sure that they wind up on the image receptor. In this case, looking at these images, one thing that you'll see in registry review books over and over again is this. If you were to shoot this image, you see this image here, these things are representative of the automatic exposure control. We're going to talk about in depth how automatic exposure controls work in our physics class, but in general, what they are is radiation detectors. And whenever we make an exposure, they count the number of X-ray photons that strike that image receptor, and they send a signal over to the machine and tell it to turn off the exposure whenever it gets the right number. So if we have direct exposure to that radiation detector, it's going to get to the right exposure really, really quickly, and it's going to underexpose the image. So in this case, what the point I'm trying to make here is that in setup of your machine, you got to make sure that you have the right ones of these activated. So if you happen to be working on a machine, you push lateral chest X-ray, it's probably just going to activate this one. If you forget to push lateral chest X-ray, it might have this one and let's say this one and this one activated, which means this one's going to get direct exposure and it's going to terminate the exposure way too early. So it's important to have these set up properly. A lot of rotation on this one. Even, I'd said that a half an inch was probably acceptable in most hospitals. In this case, that's pretty extreme. The question is, what's going on with this patient? And I'll say this over and over again throughout this semester and next semester, especially this semester. Next semester, a lot of skulls. So what we see on this patient is telemetry leads. Maybe this is as high as the patient can get the arms up and out of the way. This may be a really, really sick patient. So this may be as good as this patient could get. So what is it that they're looking for? How tough was the patient? How hard was it to get the patient into this position? And all of those things should go into, your decision whether or not to repeat an exam. What are they looking for? And how much misery is it going to cause a patient to repeat it? And certainly if you got a radiologist close, you might want to bend their ear and say, hey, can you see what you need to see on this before you go back in and wrestle this patient to try to get a better exam. So this one, the point that this image is trying to make is this was probably shot on exhalation. Maybe the patient misunderstood the instructions, or maybe they heard take in a big deep breath, but they didn't hear hold your breath. So this was really what a radiologist would call a poor inspirational effort. Really, it was just exhalation is all it was. So the high dome of the diaphragm and the very small amount of lung tissue that we have is a good indication of what we're looking at there. So I hope this was helpful. My students have a test on Monday, so it's giving you PHS, lateral chest, and AP chest. Probably do another one maybe tomorrow over the rest of the specialty views of the chest, the decubitus, maybe apical lordate and things like that, so that you'll have a little bit more study material before Monday, before the test. So again, I hope this was helpful. If it was, I would appreciate that you give it a thumbs up. If you are not a subscriber, please hit the subscribe button and then hit thumbs up. And I really appreciate you watching.